Good morning everybody and welcome to the Health and Adult Social Care Scrutiny panel meeting. We've no apologies for absence. We haven't heard from Councillor Wilson at all, have we? Right, okay. Item 1, minutes of previous meeting. Do we approve the minutes of the previous meeting? Panel, yes? And are there any items that anybody wishes to raise from those minutes at this moment in time? No? Okay. Are there any interests that anybody would like to declare?
Yes, I'm an ordinary member of Lacala.
Okay. All debates are in public, so we agree that the meeting can be held in public. Right then, item 4 is winter pressures, and we have been sent everybody's winter pressure documentation and the report at, when I can find it, I had it a moment ago, the report at page 140, which is what went to the Kirklees Health and Wellbeing Board and is the learning from last winter. So this item is a follow-up from our January winter pressure item, where it was said that the learning from the last winter would be looked at, and people would come back and discuss it with us. And so this is what this item is about. Is there anybody who's going to give a brief summary to start with, bearing in mind that we will have read the papers? Okay. I think a little integration on the winter plans would be good, but not as much paper and repetition maybe, but do you want to start, Helen? Thank you.
So thank you, Councillor Smage. Can I just emphasise that these papers and documents were at a point in time to be able to submit the documents into the scrutiny for today. And during this morning's discussions, we can ask colleagues from both the Calderdale and Huddersfield footprint and the Wakefield of North Kirklees footprint to update you on progress and developments of the winter preparedness following the submission of these reports. So I'll be asking Debbie Graham and Angela Singleton to update on the process, both the A&E group from the Mid-Yorkshire footprint and the A&E board for the CHF footprint, to update you on progress following the submission. So we have a number of papers and documents in. Phil can take us through the outcome of the evaluation of the winter pressures from last year on a Kirklees-based perspective, and we very much said that the report here today is for the Kirklees place. So we want to know what the system is doing in response from Kirklees to support our colleagues in the acute footprint, in YAS and in the Mental Health Trust to ensure that we're prepared to meet the needs of our patients during the winter period. And obviously that's in a context and background that while we do see significant pressures during winter, actually it's becoming an all-round seasonal demand these days, and we've seen peaks and troughs already through the surges that we've had in some contexts during the summer, the high temperatures and the impact that that has also had on people's health. But we are here today to talk about the winter delivery. So I think the best thing probably to do is to ask Phil if we could go through the findings of the report that was presented to the Health and Wellbeing Board in September, and then if we bring colleagues in from the other footprints, and then we can talk about the response from a social care and local community-based perspective of how we're going to pick those up during winter from a Kirklees point of view.
Thank you. So I think one of the reasons why I'm presenting this bit is when the Health and Wellbeing Board asked us to reflect on experiences over winter 17-18, I was one of the 3 people who got the job card, along with Steve Brennan, who's the Senior Responsible Officer for Integration across the CCGs in the Council, and Emily Parry-Harris, who's the Council's Consultant in Public Health. What we wanted to do is not duplicate what was done by the A&E delivery boards across the 2 different hospital-based footprints, but just think about things from a Kirklees district point of view. And rather than go through a huge sort of process of looking at the data, which is done in very great detail by the A&E Delivery Board, it was actually about having conversations with key people who were involved in working across the system throughout winter last year. So we used as a structure for that the approach that the Care Quality Commissions developed to structure their system reviews, which is something they were asked by the NHS England to start doing over winter last year. So that diagram isn't ours, it's from the Care Quality Commission. So I've included a bit of detail about what's happening with the CQC system reviews in the paper as well, because I think there is an expectation that that approach gets rolled out. They've covered 20 places across England so far. There's an expectation that gets rolled out to other places that are challenged over the coming months and years. They haven't actually worked out the forward programme yet, but we would expect to be subject to a review from the CQC in due course. Couple of graphs that were included in here didn't actually come out very well when they got printed, so apologies for that. But that's actually trying to get a sense, drawing on some of the metrics that the CQC have used to decide where to go, how soon they might come here. And if they had come out properly, it's really a bit of reassurance that collectively we're doing okay. So in terms of delayed transfers of care, certainly over last winter, the rates across both the north and south parts of the patch, and this is just looking at Kirklees residents, were lower than the England average, which is a good thing, because lower is better. And similarly, in terms of A&E and meeting the target about who's actually seen within the 4-hour target, both Mid-Yorkshire and Calderdale Huddersfield were performing better than the England average. So the context is, broadly speaking, we're doing okay. I don't think anybody would say we're doing as well as we should do, but comparatively speaking, we're doing okay. So in terms of the lessons learned, that's on page 142. I'm not going to go through all those points. I think just to reflect on the fact that literally having the conversation with people, I think, helped a lot of people reflect, because when I don't get involved in the operational planning over the winter, but when you're involved in that, it's quite difficult to sit back and reflect on what it's felt like and what we could do differently. So just having the conversation, certainly quite a few people said, helped. We've shared these lessons quite widely across a range of different fora, and hopefully people will be able to start seeing the connection between some of the lessons learned and some of the actions in the all the plans that we've shared with you. We brought people together at the end of the process and said, well, if when you look at all the feedback that we got, what are the key things? And they're listed under the next steps. And again, hopefully you can see that there's a read across there between what we found and what's in the plans. Although I think it's important to note that there was a recognition that we can't change all of those things immediately, and certainly getting into a situation where I think some people felt we've been in the past of saying, okay, so we'll sort all those things, and from the 1st of November 2018, all of those things will be sorted and it will all be okay, was not realistic, because quite a few things take time to actually develop. An example of that is just thinking about it particularly from a social care and out of hospital point of view. We know we need to complete a different model of intermediate care and reablement. We're on with that. There's a business plan being developed, but realistically that's not actually going to be in place until spring next year, because the amount of time it takes to make the changes. And similarly, we're working with the CCGs to develop a new model for clinical support for care homes, and that's in the process of going through a tender process at the moment. And again, because the timescales involved in that, it'll be spring next year when that's in place. So major changes that we're making, but we can't make them all because of the work that's involved. Sorry, we can't make them all ready for this winter because of the work involved. I think that's all that I wanted to mention.
So if we can move on now to invite our colleagues from both Acute Footprints to update what's happening through the A&E Delivery Board and the A&E Group, and the process that's been made since these plans were submitted, and the process that still needs to happen, and the sign-off. Debbie, do you want?
Yeah, thank you. Yeah. Okay, I'm Debbie Graham, I work as Head of Service Improvement, and I'm here to represent the A&E Delivery Board, which stretches across the Calderdale and Greater Huddersfield acute footprint. So the board represents, similar to the Mid-Yorkshire board that you're probably familiar with, so the wide range of system partners, and it's chaired by Matt Walsh, Chief Officer at Calderdale. We've been debriefing monthly since last winter, so we debrief after every bank holiday. That feeds into an all-year-round surge and escalation plan. You've not got that with your papers, but it's something that we can prepare, we can get copies to you. That surge and escalation plan's all year round, and it deals with any points in the year when there's any pressures, and looks at what each partner's response is to those periods. Particularly for winter, there is a winter plan that deals with things that are particular for winter, so flu, bad weather, all those kind of things, and those two documents run collectively together. In looking at in terms of the learning from last year, the focus, what was absolutely clear for that system was a focus on home care and care home capacity. So the thing that really stopped our system working as effectively was particularly home care, but care homes as well. So we focused a lot of the improved BCF funding this year and last year on that, and we've been able to significantly improve the capacity in care homes and in home care, and we can share some of that. What we also found was one of the other...
Can I just stop you there? Can I just clarify, is that for Kirklees or is that for Calderdale?
It's for Calderdale and part of Greater Huddersfield.
Yeah, it's just that community services are dealt with differently
in
Calderdale
to
what they are in Kirklees. So I just wanted to check that you are talking about Kirklees.
Yes, so the work that's been done, say, on care home provision has included both CCGs and CHFT. The other thing that came out of the learning was the risk appetite. So if one partner had a high risk in the REAP levels, so if they were looking to be high in terms of their escalation, what was the mutual aid and response from the other organisations? So we've worked hard to try and do that. We ran a live desktop exercise last week for Greater Huddersfield and Calderdale footprint to look at testing the winter plan for real, and we did that, and we got quite a lot of learning. Our plans have been shared with the A&E Delivery Board from September. The desktop exercise ran last week. We'll be putting that learning into the revised plan, and the revised plan will be signed off. We've got an A&E Delivery Board meeting this afternoon where we'll be looking at the output of the live test, and then the final version will be signed off in November. That's all, thank you.
Hi there. So, similar to what my colleagues... Is that any better? Is that okay? So, similar to what my colleague said there, we reviewed the lessons from last winter and we put in a transformation programme focusing on key areas that were identified. So there's 8 work streams within there, and that's a 2-year programme, and it's in recognition that actually the challenges that we face are all year-round challenges, which is probably fair to say get maximised during the winter period when we're arguably most stretched. And where we're at now is we're in the process of just finalising those winter plans. So we've got a more up-to-date version that we're working on. And also the planning is continuous. As we saw last week, there was an announcement from the government about money for social care to help manage winter pressures. So I think we're still awaiting details of what that allocation will be, how much it will be, and then we'll have an idea of how we can go about spending that and making use of that for winter. So we've got an A&E improvement group for the Mid-Yorkshire system, which covers North Kirklees CCG and Wakefield CCG, where we'll have that more up-to-date plan next week with further updates around what the acute trusts are and all our partners such as Kirklees Social Care, Locala from the community side of it. I think that's really it in terms of where we're at.
Hi, can everybody hear me okay? Yeah. So in terms of Locala's planning, our challenge, a bit like our local authority colleagues, is that we've got obviously 2 CCGs and 2 acute trusts on our patch. So part of the work that we do internally is to reflect the planning that's been done by both A&E delivery boards, and then we have a process internally where we can align that. So for our teams out on the ground, we can give them as much consistency as possible. We don't always get that perfect, but there will be some differences in how we have to deliver services to meet the needs of the different hospitals on our patch. But as much as possible, I would say the vast majority of it we deliver consistently across Greater Huddersfield and North Kirklees, but we have to have that bit of flexibility as we align our services to the needs of the hospitals and how YAS works and how social care works in those different areas. So we deliver a range of services which support the hospitals, and we work alongside in an integrated way with social care as much as we can. And I would say in particular this year we've probably gone quite a long way towards how we integrate services, and one of the things that we've been doing as part of that is to make sure that we're avoiding duplication where our services work together, and that's just as a way of trying to maximise the capacity we've got in the system, and that's a process that will be progressing over the next few years as well, as a way of just trying to be more, I suppose, cleverer with our resources across our social care partners and health in the community. So what we deliver in terms of winter is we've got a range of intermediate care services which are based in the hospital from our START team, which is the team that goes in and supports rapid assessments with the aim to get people out of hospital as quickly as possible. The other part of that services remit is to also try to avoid hospital admissions as much as possible. So the other challenge for us around community delivery is how we I suppose deliver both ends of the system. So we've got that role around supporting hospital discharge, but we've also got a role around trying to prevent hospital admissions where we can as much as possible, and it's the balance between the two. And in terms of that balance, that will shift at different points in the year in response to pressures in either HRI or Dewsbury Hospital, which is where our main acute partners are based, and that's where our teams will be working on a day-to-day basis. We have intermediate care beds, which we have both around hospital discharge but also step up as well. So that's our way of supporting people who don't need to be in hospital because they're medically as well as they possibly can be, but aren't quite ready to step back into going home. And we also have a service which is integrated with the local authority, which is around reablement. So intermediate care and reablement, their main role is to rehabilitate people and to maximise as much as possible their capacity to get back to normal functioning and stay well at home in the community. And that's about ensuring that they've got the right support in there as well. So we've got a range of community services that, if they're not responding at those points of acute need, either to keep people at home and avoid a hospital admission or to help them come home as quickly as possible, we've got a range of other services that support. So that's including things like community therapy, district nursing teams, our specialist nursing services who work with people with long-term conditions, and that's all about getting proactive plans in place. That's the part of the system that works right throughout the year, but part of our internal processes around winter is to work out how we target some of those, what we call wraparound services, to the patients either in most need at that point in time who tend to become unwell in winter, and do something proactive with them around ensuring that they've got their clinical care plans in place, but also for those services to identify and respond very quickly to patients who are becoming unwell. And that can be through one of the specialist teams, or it can be through our community matrons who work with GP practices to manage some of the more complex patients, or, as I said earlier, directly with the hospitals through our START team in conjunction with rehab and reablement. Okay.
Hello, David MacDonald, Adult Social Care. So what we've been doing is we've been looking at working in partnership with our colleagues in both acute trusts. We've already started with kind of doing some winter planning and a bit of winter preparedness. We're doing weekly calls with our colleagues in the trust to make sure that people that are identified on the transfer of care list are escalated through the system, and that we're looking at kind of making sure that we don't get the blockages there. Around domiciliary care, we've started obviously implementing the new contracts, and we've been doing some work there around ensuring that the waiting lists are being reduced, and that we're also getting the number of hours up, and we've got a person dedicated and working on that currently. Within the care homes, we've got the new bed state tool and also the red bag system, so that helps the hospitals to ensure that anybody that's been discharged out of one of the care homes that desperately needs acute care has got all their information with them, and that's going straight the way across with that. Within intermediate care, working in partnership with our colleagues in Locala, what we're doing there is we're ensuring that people that are coming out of hospital that need additional rehab are being supported, but that our colleagues in social work are ensuring that those people are getting a forward plan, that people know where they're going to, and that we're making sure that people move through that system as quickly as possible. We've got a new service that's come online as well, which is Enablement Plus. This is kind of a really short-term service that will help the hospitals, because this is for folk that maybe might not have been discharged under normal circumstances, because they might not be able to go home without some support at night. What this Enablement Plus does is it kind of looks at a really kind of person-centric way of dealing with the person's requirements, care, what their needs are, and then builds a unique service around that person for the first kind of 48 to 72 hours to ensure that they're supported out of hospital whilst everything else is going through there. We've got another service that we're currently looking at starting on the 1st of November, which will absolutely help the trusts, which is the choice and recovery beds, and we're working in partnership with our trust colleagues there. And what the choice and recovery beds is, one of the issues that we have around transfer of care is when somebody's been identified as requiring ongoing 24-hour nursing care in a care home or into residential care, quite often we get a block there because families, quite rightly, are involved in choosing the right care home for that person, yeah? And what that does is kind of blocks the beds. So what we're doing is we're looking at commissioning 5 beds in North, 5 beds in South, which are nursing beds, and also utilising our 2 internal care homes, our EMI homes, to have 3 residential beds North, 3 residential beds South, so that we can discharge people safely from hospital. They can go into those beds for 2 to 4 weeks, whilst the family ensure that they've got the right ongoing support for that individual moving forward, and that they've chosen the right care home for those people in the future. So we are doing quite an awful lot, really, but I suppose from a social care point of view, we're ensuring that our social workers and assessors in the hospitals are getting a lot of support. So we're doing workload management with those folk every week, so that we've got management oversight of all the cases, and that we're ensuring that people are closing those cases down and moving those cases through as soon as possible. Myself as a head of service, and my colleague Simon, who's head of North Social Care, are on calls and going to detox meetings to ensure that we're supporting the trust as best we can possibly support them to get people out. We've put care navigators into the hospital teams as well, and they're supporting people who are self-funding, they're supporting people who maybe not would not have been discharged because they might be on the hoarding pathway or different social care issues there. And we've also got support from colleagues in Community Plus as well around supporting people going out of hospital and getting more connected back into the community.
Thank you. Right then, open it for questions then. So David and then Peter.
Thank you. I've got one overall point and two specific points. Just overall, there's a lot of paperwork here. Some of the details are very interesting, but there's a danger of not seeing the wood for the trees. So my plea would be in future if there could be a focus on what didn't work last year, whenever last year was, and what's going to be done about that, what did work but could be done better, and then what new things you want to do. And just maybe 2 or 3 A4 sheets just summarising that would be really, really helpful. So that's the overall point. The specific points are arising from the report that went to the Health and Wellbeing Board. First of all, it's what do other people, or what do people think about how it went last year? And you've got results of a survey you did with 40 people, it says, but I assume that means staff. And then in section 3 of the report that went to Health and Wellbeing Board, the bottom point emphasises about losing the patient's voice in the pressures of winter. So, and that is a danger which you recognise. But my question is, if you were able to do a survey of 40 staff members, would it be possible in the future to do a survey of a number of patients so that their voice isn't entirely lost in this process? I'll come on to my second specific point in a minute.
We had some discussions with representatives from Healthwatch about how we could do that. We had a quick look round to see if there were other places that were doing it, and to be honest, we couldn't find anywhere. So if people have come across places, that would be really interesting to know. Conversation with Healthwatch. Again, the logistics of it, and this is partly to do with being able to access people who've been through the system over winter and get the right permissions in terms of GDPR and data protection. We struggled, if I'm honest, to come up with what felt like a workable and affordable system for doing that. Where it finished up was a suggestion that we actually have a conversation with community-based organisations that are working with people about what they're hearing about people's experiences of the whole process. Because what didn't feel like it would be particularly useful is to replicate the work that's done through the hospitals and GP patient participation groups about that ongoing feedback loop between people who are using specific services and the patients and their families who are experiencing it. So that was as far as we got. We know that it's something we need to do more work on. What I'd highlight as well, to follow on from that, is when we had conversations with people in primary care and to an extent social care, we recognised that we hadn't got that feedback loop right either. So there were plenty of GPs and people working in GP practices who their reflection was, our experience of winter isn't reflected in what we're doing around winter planning and similarly social care. I don't know if other colleagues have got things to add in terms of what we can do around sort of patients, carers.
Well, yeah, just a response to the initial point I made about overall, just a brief summary of what went wrong, what went okay but could be improved, and what new things need to be done. And then I've got one other specific point as well.
In terms of trying to pull that summary together, I think we tried to start doing that with what we did in terms of the winter review. There was an extent to which it felt like we were starting to duplicate, because I think everybody who outlined what they were doing as part of their mechanisms, whether that's Calderdale and Huddersfield, across Mid-Yorkshire, local, everybody does their own internal sort of review. I think now we've done this piece of work, which is about getting, if you like, the qualitative reflections. I think what we can certainly make sure we do for next time, and that's next year, is to make sure we actually focus more on the practicalities, because it felt this year it was quite qualitative, and I think we can be more quantitative in terms of the practicalities of what, exactly the points you make about what we did, what worked well, what didn't work well, what we're going to do differently next year.
Thank you. And my second specific question is on the Appendix 1, the proposed actions. So it's getting on to the practicalities, really. That's quite an interesting table, but I'm not quite sure. You've got the three categories: in place, planning, and new idea. There's no dates on this. And also some of the things that are in the planning column, emission avoidance particularly, which occurs 3 times in the planning column. Just a question really is that not already in place? Or what aspect is in planning when emission avoidance is such a key issue?
I think what we were trying to summarise there is a huge amount of activity around emission avoidance that's already in place, has been for quite a long time, and that keeps evolving. These are about specific new things that we felt could be done, and we were trying to draw the distinction between, in effect, ideas people were putting forward where we thought, yes, we think those are already in place, but we probably need to just check and make sure they're doing what they should do. Planning was something that we knew wasn't in place, but there was some work starting to put it in place. I mentioned some of the things earlier around the integrated pathway of community service. I was struggling to find it then. The new idea was basically ideas that came out of the workshop that we had at the end of the process, and we weren't aware that anybody was actually doing any work on those. So that was the way of categorising them. We didn't try to capture every single thing that was going on around each element of that.
Perhaps illustrates one of my difficulties anyway. If there was more detail on this kind of table, so you could sort of see on emission avoidance, we're doing this already, but we've got some new ideas and these are those, that would help us to understand how things are progressing and how the system's improving over time.
Yeah, just to pick up on the patient's voice there, the next steps and your actual table, there's not a lot there about making sure that you have the patient's voice in all of this. In fact, it's very absent. I think we definitely noticed that is not there. But Peter, do you want to come in?
Thank you. I think we can all see the vast amount of work that's gone into this, but like the chair and like Dave, I think we've got kind of 4 atomised reports with the ambulance service chucked in, and yes, a lot of them say the same things, and it is sometimes difficult to see how it will join up, but I'm sure it will. On which I wanted just one general question, please. Is the surge and escalation plan, is that the same as OPEL?
Yes, so surge and escalation plan was based on OPEL levels, and it's now based on REAP levels, and I can't off the top of my head confirm the acronym in full, but it really is about operational identification of, through a number of triggers, what level you're at, and so that helps us work out what each individual organisation's REAP level is, what the REAP level for the system is, and what are the responses that each organisation needs to provide to perhaps that potentially, say, the acute trust where their pressures are building. So it allows us to kind of, from a data point of view, assess where we are. So they are the same but slightly different.
Right, thank you. So what you've done, you've adapted it for your own purposes, presumably?
The REAP process comes from the Ambulance Trust. It originated there. And what NHS England suggested that everybody adopts a consistent approach so that systems, when they ring their systems on a Monday morning, which they do across West Yorkshire, they can understand where everybody sits from the same baseline.
So that's why NHSE are involved?
REAP levels, yes.
Yeah, because I wondered, is that also possibly associated with the thought that you might, if A&Es are overwhelmed, that you might start to export patients to Leeds or Bradford? Is that, are NHSE involved in that?
So NHS England would seek assurance each Monday morning that the systems are doing what is in their plans, so they have a copy of our plans. They would be saying, you're at whatever level, you're at level 3. We assume you have taken the action set out in your plan, whatever they might be. And they would be seeking assurance that we've done that from the CCGs on behalf of all the partners. So that phone call takes place generally in winter every Monday morning, early on to each partner. And then NHS England call is 1 o'clock with each system to say, where are you, what are you doing, can we be assured that you're doing everything you need to be doing. And sorry, I did get it wrong, we've moved from REAP to OPAL, not OPAL to REAP. So just to confuse things completely. Apologies for that.
No, that's okay. I mean that's not the most complicated acronym in these, I can tell you. I mean, if somebody can tell me what a CITREP OPAL declaration in ICCTS is, I'd be absolutely grateful. page 109 for pedants. Yeah, I mean, more seriously, then just to come back to practicalities, just wanted to ask about 4 things. One, the things that confront you. One is staffing shortages. The second is preventing admissions. The third is managing elective demand. And the fourth is reducing stay. Now, you've alluded to all those things, and I wondered if we could just take them one by one and just tell us in kind of words of one syllable. And let's start with staffing, because you say that you've got a memorandum of agreement between a lot of providers and that you're going to bail one another out on staffing, and that possibly the private sector will be coming into HRI to bail you out. You know, if you could just elaborate on that, on staffing, first of all, please.
Thank you. So I think what we've got is a memorandum of understanding that's more around making it easier for staff to in-reach into one organisation from another. So, for example, with Locala and ourselves, or with Mid-Yorkshire, if those members of staff wanted to come in and assess patients, set off some pathways of care, it's easier for them to do that from a contractual position. I think what we tend to find across West Yorkshire, when one organisation is busy, the whole of West Yorkshire is really busy. So whilst, you know, we will have our local system calls from a coup perspective, we regularly talk through winter and share some of that. So I think it's less around staff moving wholesale into one organisation to help them with staffing, and more around it just allows them to see patients wherever they are without us being hung up on contractual forms.
Thank you. It's misleading because you talk about sharing staff. If you're not doing it, don't say it.
Sorry, if we could, we would. So I think it enables us to, if that was the case, if one organisation wasn't as pressured, then actually we would do that. And we have tested it. So going through, coming out of winter this year, we certainly tested that over the Easter bank holiday to see if that worked. But I think our general perception is if one place in West Yorkshire is busy, West Yorkshire is busy.
Thank you. The second one, prevention of admissions, and if we could focus in the first instance on what do you know about the status of the immunisation programme for flu?
In terms of both bits of that, in terms of the flu, then we've certainly been given some very clear directive from the Department of Health around expectations of 100% of our staff being immunised. I think that goes across most of our organisations. We've already, we're not the only organisation, I think, who've already launched that and started. We've got a better vaccine this year. around that. And in terms of our patient admissions, we have also invested in point of care testing. So where previously the test for patients who turned up with query flu meant actually we ended up admitting them and isolating them while we got that back. We've all doing that, so actually at the point that the patient presents, we can get an instant confirmation, and therefore we can plan their care accordingly. I think there is an expectation that we redeploy staff who refuse to have their flu vaccine. Some of that is a bit more easy to deliver than others, so it's hard to redeploy an orthopaedic consultant who refuses to have their flu jab. But I think we're having slightly different conversations with all of our clinical teams. I hope that would probably echoed across all of our organisations.
I was interested actually in the at-risk population in the community who are going to be filling your beds. I mean, what do you know about their immunisation status?
Just from a specific around some work that we've been doing with our GPs, so actually we've supported our district nursing staff with honorary contracts, so actually they can support the GPs in getting out to those vulnerable patients and providing them with a flu vaccine. We took something that was slightly outside of the original NHSE guidance, but we felt it was the right thing to do for our population, so we've been working actively with the GPs to do that.
That is in Kirklees, because the district nursing staff is not with CHFT in Kirklees, it's with Locala. So can we just double check that that is what's happening in Kirklees?
The position in Kirklees is as NHS England directive, which is that the GP practices take responsibility for immunising their patient cohorts. We've got an arrangement with some of the care homes, so obviously if people come in and out of our intermediate care bed bases and they haven't been immunised, we've got arrangements to be able to immunise them while they're in with us. And equally, some of the care homes have approached us as well to see if we can support their residents getting their vaccines. So we've got some individual arrangements with some of the care homes as well to support them where they need it.
Thank you. And the third one, please, managing elective demand. There's a suggestion in here that you cram as much elective work into the first 9 months as possible. And I just wondered how you managed to do that and you know, whether you don't have waiting lists anymore.
Hello, apologies for being late. I'm Trudy Davis, I'm the Chief Operating Officer at Mid Yorkshire. We do have waiting lists, yeah, absolutely. The priority over winter is cancer and urgent patients, so we will always prioritise cancer and urgent patients. We're lucky in that we have protected elective environments, both at Dewsbury and Pontefract, and we use those to maintain elective activity, which meant last year we didn't cancel any cancer or urgent patients at all. We did have a planned reduction in some of our elective activity because the staff that we needed, which we referred to earlier, were absolutely needed on the front door and the acute pathways to try and manage length of stay and reduce admissions where possible.
So that means that you redeploy your consultants in other ways over the winter months. If they're not doing elective work, I mean, are we sure that they're not doing it in the private sector?
No, we keep a very close eye on what our staff are doing. But, for example, our consultant ophthalmologists aren't really what we need in A&E at the front door, so we continue with ophthalmology work. Things like trauma and orthopaedics, we deploy them to more acute work, particularly after such things as a slippy day where we see more patients presenting with fractured wrists or hips, and we would convert their work into acute because that becomes an urgent service. So it's very much a specialty-based response to make sure that we address the needs of the patients that are with us at that time.
And the last one, please, discharge, reducing stay and delayed discharge.
I mean, from what we do, we're doing an awful lot of work currently around reducing any stays, particularly around kind of like super stranded and stranded patients. So we're working very closely with our colleagues, and where things are identified that it's a social care issue, what we can do is we dynamically move in resource from community teams, if it's required, to ensure that people in the hospitals are getting a timely assessment and that we're able to move people through the system a bit quicker around that.
And your overall assessment on the sort of state of readiness in intermediate care, I mean, I think you just mentioned it earlier, but that's better than it was last year, presumably.
Oh, sorry. Do you want... with intermediate care, we're currently doing a massive review of intermediate care. We're working with our partners, Locala, very, very closely. We're looking at having a completely different response. That will not be ready for this winter, but we are doing some incremental changes. For example, the new Enablement Plus service, which is kind of, we're piloting that bit where we're looking at more of a wraparound, personalised care package for somebody being discharged out of hospital to get them out of there sooner. And I think that there's an absolute recognition from social care that hospital is not the place for people to be. People really do need to either go home or to the place that they call home as soon as possible. I'll let my colleague Rachel.
So in terms of the health part of intermediate care, we provide the nursing and therapy. So the local authority provide the care staff in those beds, and we provide the nursing and therapy. And what we've done, learning from last winter, is we've changed the mix of nursing to therapists slightly in the bed bases, because obviously the focus is on therapy and getting them as physically fit and able as they possibly can be. And we did a big an audit and review of our patients that were coming through intermediate care, and we worked out that actually putting a little bit more therapy input in there, particularly over a 7-day period, helps actually shorten the length of stay in intermediate care, which by default then helps to shorten the length of stay throughout the system and keep things flowing.
Just going back, and I'd just like to reiterate what my colleagues have said in regards to the patient's voice. And something that you've said literally bugs me. It says nobody else has done it before, and you mentioned other areas. And I just think that's not really good enough. And obviously, we know that the fact that, you know, a patient's voice is very important, and not just saying it, you know, other areas haven't done it. So I just needed to, it was bugging me, I needed to get it out, basically, and I had to say this. Just a point, quite a few of the things my colleagues have actually already said and spoken about. The 100% flu jab rates for staffing it's for staff, and the rest of it obviously goes back onto the community, so that the GPs are responsible for obviously ensuring the community. How much work has been done with Locala to make sure that that this has been uptaken by the GPs and that actually has gone out? Or is it just been basically been the case of we've given that responsibility to the GPs and they're going to deal with it, but you know, there's no monitoring on that or anything like that?
Hi, it's Julie from North Kirklees CCG. I work across both CCGs. The flu programme in general practice is something that they do every year and they plan for. We work with them. We've actually given an advice booklet this year on best practice, but it's something we try and strive for continually to improve on uptake every single year, sharing best practice at our cluster meetings. So some practices who do better than others, but what have they done different? How have they managed it? So it's a continual improvement cycle really for the flu vaccines that's ongoing, and we monitor it every year in detail and share the monitoring back with the practices.
I just think we know that that's one of the key factors in this. If there's something more we can definitely do, just monitoring it and not actually putting some kind of guidelines to say, well, you need to make sure this happens, would be a good idea. I mean, I know whether we can enforce it or it'd be something completely different, but something like that would be really good.
Yeah, just to say, with regards to GPs, there's a national flu plan and there's some guidance in there around the expectations that GPs are meant to take, such as communicating with eligible people that for the different types of vaccines. And as when we check up on those practices with perhaps lower flu rates, we look for assurance that they've followed those guidelines.
Yeah, I was just going to say, from a Locala point of view, although we're not physically giving vaccines this year, we're still working with our teams to obviously promote that. So where we've got, for example, people who are eligible because they've got a long-term condition, our specialist nurses are working with those patients to make sure that they're going to the GP practice and reinforcing the need to get the flu jab and the pneumococcal vaccine as well, which is the other part of the vaccination programme.
Sorry, can I just go on to, so in regards to trying to prevent hospital admissions, what work has been done again in the community to make sure that they are a bit more aware of what else can we do? Again, going around in circles, but it's a case of what other kind of work has been done. There's very little information on social media. There seems to be very little information that's been sent out to the community out there. I'm just trying to find out what is it that we've actually targeted to do, really.
Kind of to answer that, well, part of the work that we're currently doing with our colleagues in Community Plus, which is sort of like the community arm of the social care service, is that they're doing some specific kind of bespoke programs of work at the moment. One of those is around UTIs and prevention of UTIs, and there's, sorry, yeah, urinary tract infections. Sorry, yeah, please remind me. We all talk in this language, don't we? So that's around helping people to kind of be more be hydrated, make sure that that they recognise the signs of things like that. Community Plus are also supporting people out there with prevention of falls as well, which we know is another big area where people are getting taken into hospital. They're working with kind of the cohorts of people that are identified around that. Our colleagues in public health are also looking at kind of how we can support the whole community in blocks of between 30 to 50,000 people. And we're working with the primary care network, so groups of GPs that are coming together to ensure that we're looking at a whole population response to support people. And that's hopefully going to increase kind of the well-being within the community, and that will hopefully reduce the number of admissions into the acute trusts. Is that okay?
And there's another facet of work going on around that point. So across West Yorkshire, there's a comms plan where we're working together to just help look after vulnerable people in there. So, and it's something everyone can get involved with. So I think they'll be looking at fixed social media campaigns, like you pointed out, and things like that. Because I think, as my colleagues from the hospital would say, every year we still see vulnerable people, especially when we get those slippy days come in with injuries that potentially, if some of us are a little bit more better mobility, if it was help putting the bins out, or bits of shopping could have prevented. So, and that's something we can all get involved in.
You mentioned Community Plus. I mean, Community Plus is quite new itself, and then I know I can speak about the areas that I represent at the moment. Community Plus isn't functioning or anything like that, so it's a case of stuff that was happening last year and you're taking learnings from it this year, but in many other places Community Plus are still restructuring themselves, so just obviously having the onus on Community Plus for this year isn't going to be, I mean, it'll be good for the future once everything's sorted out, but immediately obviously we're still in a bit of a limbo in terms of what's going on with that. So thank you.
On page 142, point G, you've indicated the challenges around the nursing homes. I mean, somebody did mention earlier on about the care homes. Now, if these people are in need of a place and they're not getting a place in the care home, and you've also got your staff shortages, what backup plan or what is there in place for these individuals that can't get a place?
I'll start off, but I'm sure other people have things to contribute. I think one of the things that came out of the winter review, and I think it's borne out by current experience is the specific problem is around nursing homes and particularly places for people who've got dementia. And that's partly to do with the availability of staff. So that's the specialist nurses who can work in nursing homes. Well-rehearsed nationally problems around sort of recruitment of social care staff generally, and that is also an issue, and that's something we're dealing with by taking a much more creative approach, particularly a social media-based approach around recruitment across the board. But there is a very specific challenge around making sure that nursing homes have got the specialist staff they need to actually maintain their registration, to keep providing services safely and effectively. I think the other aspect of that is, unsurprisingly, the amount of money around in the system. The government's been working on a green paper for a number of months. It's due shortly, which is about trying to restructure basically the entire funding basis of social care. So there are practical things that we are doing locally, but we need to recognise that there is a national issue about the funding of social care. Whilst short-term announcements of additional money are welcome, they're not actually addressing the root cause of the problem about the funding issues across social care.
Just to sort of expand on the stuff that Phil mentioned earlier about the working care homes. So there's a big piece of work going on across the whole of Kirklees, a procurement for a care home support team. It's a care home support team that already exists in Greater Huddersfield that's been expanded and built on to cover all Kirklees. And the idea of that is to ensure all patients in care homes get care planning, end of lives identified earlier and appropriate plans put in place. Education in care homes needs are identified and additional education put in place, and also an admission avoidance role for the team. So there'll be some telehealth element in there, so any urgent clinical requirements from the care home can be met by some telehealth advice in the first place, and then a visit in 0 to 2 hours by the care home support team if the patient needs seeing on a one-to-one basis. So that piece is going under procurement, and we're hoping that will start in the spring. But that service already exists. Locala provide that service in Greater Huddersfield now. Alongside that, there's work going with colleagues across West Yorkshire around care homes. So I was at a meeting yesterday where Leeds across West Yorkshire were bringing collectively their knowledge and expertise around the care home market and the issues in care homes, and looking at how we could do something together across the whole patch to improve quality of care in care homes. The last thing to mention is over the winter period we're looking at funding some choice and recovery beds. So where patients might end up staying in hospital longer than they should because their care home of choice isn't available, we've got a certain number of beds that patients can move into for a temporary stay for up to 4 weeks, where their needs will be met and they'll be reassessed, and it might be that they go to their care home of choice during that 4 weeks, or it might be that they could actually go home if they're improving that 4 weeks. So that's something we're putting in for the winter period.
Okay. I just wanted to add on a point about different options in terms of where people can live more independently. One of the things we're putting a lot of time, effort and resources into is developing a much wider range of specialist accommodation. So rather than it being quite a binary choice between do you go back home with support or do you go into a care home, there are actually a much broader range of options for people who've got different levels of need, and there are different levels of support.
I've got a couple of points that I'd like to raise, please. The first one goes back to the directive for GP practices to take responsibility for flu vaccinations for their patients. And I just want to ask, is there an optimum point for flu vaccinations to be administered? And is there a related target date for GPs to work towards as regards completion of the vaccination programme. I'm thinking about GP accountability really, with a particular focus on vulnerable housebound patients, because in previous years I've personally encountered examples where people who are housebound have got to November and they've still not had their flu vaccination. And whilst I appreciate that there might be a perception that being housebound means that you don't get out, so you're not at the same level of risk as others, in fact I would advocate that these people are at more risk because they're visited perhaps 4 times a day by care support services, often different staff attending on that basis, and also by family members, including grandchildren. And so I think it's really important that if we're looking at prevention and early intervention, that we have something robust in place to address those concerns.
It's Julie again. Yeah, GPs have plans in place to start giving out the flu jabs as soon as they come in, so that the plans are already there, and the flu jabs usually come into practice. It can be mid-August that they actually can land. It can vary year to year, but the plans are there. So they'll, for the mobile patients, they'll have clinics, so they might have a Saturday morning, or they might have certain days where they do flu jabs all day, and they'll invite those patients in to get the majority done. And then they'll give vaccinations ad hoc as people come in for general appointments, but they also have plans in around the housebound, and they all know that they've got to get their housebounds done as soon as possible. So they I'd say by mid-October, the aim would be to get most of the jabs done where they can. There will be delays if patients aren't well or they've been admitted to hospital or whatever, where it might end up being longer, later than that, but the aim would be by mid-October to get the majority done. And they do, planned cancellation of other clinics to focus on flu and get them out their fridges, because they haven't really got room in their fridges to keep them much longer either. So it's an all hands on deck type approach usually. Each practice will have its own plan.
And are the GPs required to keep a database relating to their vaccination programme, and who actually monitors this and holds them accountable if there appear to be unreasonable delays?
They keep a database. Everything's recorded on the clinical system, and they do reports into NHS England every week. Certainly we monitor, as a CCG, will monitor the uptake, and if we see a practice that's got a low uptake, we'd investigate that and look at that. And the primary care teams are looking at this constantly throughout the winter period.
And if a GP practice is particularly struggling to deliver their vaccination programme by the optimum dates, perhaps due to circumstances beyond their control, maybe GP absence on sick leave or for other reasons, is there a partnership approach that can be employed whereby the GP can admit that there's a problem and seek support, rather than, in other words, a proactive approach, rather than a reactive one later when we suddenly realise it's November and there are patients who still haven't had their vaccinations?
Yeah, our primary care teams are there to support and help them, so anything that's identified early should be picked up and an action plan put in place. Our GPs also work in clusters or groups, so they can help each other. We just have to get over any indemnity and record sharing issues, but certainly if they raised an issue, we'd look to how we can support them to manage it.
Thank you. That concludes my questions relating to the flu vaccinations. And really, I've just got an observation to make about the chart on page 24, please, of the report. And just to say that I've noticed that there is only one representative from the South West Yorkshire Partnership Foundation Trust, and I would just like to say I'd like to see more than one representative with a degree of expertise in what the Working Winter Group is seeking to deliver. I just feel it's perhaps not best practice to just have the one representative from any individual organisation. So I'm not asking you to necessarily respond today, but it's just an observation to be noted, please.
Thank you. Yes, my question's on the high impact changes that are required to reduce delayed transfers of care, which we've touched on already, but it's the on page 25 or page 11 of your report. It lists the high impact changes. Could do with that font being slightly bigger. But the table beneath, I'm not quite sure how that's structured, on what message it's trying to get across. You've got the assessment down the left-hand side as to the stage at which the high impact changes are at, and then a list of the high impact changes across the top. I'm not sure about the dates on there, and I'm not sure about the difference between the yellow boxes and the green boxes. And maybe something of a narrative on this would be quite useful, because it's pretty essential to the whole topic we're discussing this morning.
Okay, this is the piece of work that was done in the Greater Huddersfield and Calderdale system. So, as you set out, the framework is actually prescribed as part of the document that came out originally, through which excuse me, systems can self-assess themselves. So, really, what this shows is the progression. So, through those self-assessments, the first self-assessment were done in April, 16. Sorry. And so you can see the green are where the last self-assessment excuse me, where the last self-assessment was done, and that's the point at which that particular part of the system currently rates itself, the green boxes. So hopefully you can see the progression of the work since the first self-assessment done in 16, then through 17, and then to April 18.
Can I just add before Debbie runs out completely? That process was actually part of the sort of Better Care Fund assurance process. So a similar exercise was done in North Kirklees as well. It was one of those exercises that we had to try and disentangle a bit the Kirklees element from the A&E footprint elements. So, like I said, there is actually a similar assessment for North Kirklees, and it's a very similar position. It's just a matter of style as to whether or not it got included in the plan that we've shared with you around Mid-Yorkshire. So we have got it across Kirklees.
Okay, thanks. I suppose that comes back to the point I made earlier about the focus of the report and the important things being the practicalities and what's working well and what's not working well. And I think perhaps in terms of a lot of this is about service integration, and the other aspect of that is, in my mind, report integration. What we've got this morning is a series of reports by different organisations, and there is an attempt to try and pull things together with the covering report and the copy of the report that went to the Wellbeing Board. But it still looks quite sort of disparate and separate organisations working, a little bit of joint working, but full integration is not there. And you do actually refer in the covering report to the sort of principal elements of integration, which, interestingly, when I read that, I thought, yeah, I remember reading that 20 years ago. So none of that is new. It would be good to see a further movement towards a fully integrated report on winter pressures issue within Kirklees.
It's difficult, would be my comment about that, because if you're Helen or Trudy and you're trying to run a hospital that's taking patients from across different areas, it is difficult, and I agree that a lot of this is about integration. Not everything is, and it's one of the things we've recognised for a long time, that it is a challenging set of footprints that we operate on, because particularly because of the way hospital services are organised, but the same is true of ambulance services. One of the ways we approached pulling things together was to say that the A&E plans that we've, the A&E delivery board plans we've got in here actually cover people who don't live in Kirklees. The specific organisational plans are the ones that just cover people who live in Kirklees. Stitching those together to make it all feel like it's fully integrated is extremely difficult.
Yeah, my question's about the specifically page 51 of the Mid-Yorks report, where under what went well last winter, we're told that ambulatory care helped to take people from ED, and that's in the context, I think, of the ambulatory care centre due to be being closed for a significant part of the time, and I'm interested in how that ties up.
Can we just wait for the next item for that? I'll bring you in again, Nell. Okay, I'll listen. Yeah.
Hello, I've just got a question. I know we've touched on staff shortages, but I was wondering while I was reading through this if there's a plan in place for if we don't get a deal with the EU in November. How that, if you know, lots of nursing staff who are from Europe decide to leave our country and go back, how that will impact upon the services and your winter plan. And additionally, as well, if we don't get a plan in place with an agreement with the EU, then will that not have an impact on medication as well? And how will that affect your winter plan?
Good question. So the government a few weeks ago issued some technical guidance around how the NHS should prepare in the event of a no-deal Brexit. So around medicines, as you mentioned, the government's working with pharmaceutical companies to provide some stockpiles around that. And the guidance that they issued for us locally was that essentially there was nothing for us to do because they're working with the drug companies, so we don't need to stockpile medicines or things like that. With regards to staffing that may come from EU countries, there's a toolkit out there that can support staff in registering and so that they'll be able to stay after Brexit if there is a no deal.
Okay, thank you.
Any more questions on this item? Peter, just one more, and then I'm going to draw it up.
I just wondered from the point of view of Locala, and we have asked this before, and please, I don't want to be repetitious, but how much of this is a stress test of your eventual ability to cope when we don't have as many inpatient beds in this town? That's my first observation. And secondly, I just wondered what statistics you're keeping on how successful you are at keeping people out of hospital.
Okay, on your first point then, yeah, anything that we do that tests our resilience in different ways, it gives us an indication about what the potential impact would be if there were changes in either of our acute trusts. So yeah, winter is a good way of assessing some of that. So what we've done you've got our winter plan as part of the pack, but what we've done internally, and it comes back a bit to what I said earlier about the fact that we've got a slightly different setup on in North Kirklees and Great Huddersfield. So we have an internal meeting right through the winter, which brings together all of our operational services and teams that either contribute towards directly towards supporting the hospitals and working with our local authority colleagues, or if we get into times of high OPAL levels and we need to start thinking about prioritising some services over others, it's our process by which we do that. So that's well tested through last winter, and some of the things that worked particularly well were some of what we would call our lower priority services that don't provide very acute responses when people are in emergency situations, can work with our commissioners to agree that we will deprioritise some of those patients so we can actually focus on some of the patients at high need. So they're the types of patients that potentially would need things like intermediate care or some of the reablement services, those wraparound services that David talked about earlier with things like night sits, are ways of providing alternatives to inpatients where patients are medically stable and well. So how we normally try and think about it is that where you've got sort of on a hospital site, you've got a set number of beds. We often think of our beds in the community as each patient is in effect a virtual bed in their own home, and that helps us look at where we've got demands in the system and what type of needs those patients have, and that's all built into the planning that we do for this. Just remind me your second question.
The second one was about the indices of effectiveness. You know, how many people are you preventing from going to A&E? How many people are you managing to treat at home with IV drugs? How many bed days are you saving? We've asked you all these things before, but without any numerical or quantitative indicators, we can't see, because you tell us you've only got the same staff and the same resource that you had last year. So, you know, how are you going to cope in the future when there are no acute beds is just a bit of an imponderable for the people of this town.
Okay, so as part of our Care Close to Home contract, we've got a number of performance indicators. So that tells us things like, I suppose the first thing to think about is prevention is difficult to quantify, and this is an age-old problem we've got, that if you prevent something from happening, how do you evidence that? So the best you can do is to have a number of what we call proxy measures in place to help us assess whether something's been prevented or not. So for example, our START team, which does the rapid assessments, so if somebody needs an urgent intervention, we will go out within 2 hours and assess them and put in whatever intervention they need. So they're kind of right at the front end of it, where you can say that every time they intervene with a patient, potentially prevented a hospital admission, because if that didn't happen, they potentially would have needed to go in an ambulance and may have ended up in A&E and then onto a ward. So there are certain services where we can say if we do a really, like on the day or within so many hours, if we go and intervene, the likelihood is we've prevented a hospital admission. But in addition to that, we've got things like within the KPIs for Care Close to Home, we report on things like IV. You talked about IV earlier, so we know exactly how many IV therapy interventions we're doing with individual patients. We measure how many emergency care plans we've got in place with some of our patients with long-term conditions and complex needs, and how many times our community matrons interact with those patients. So all that there's a vast amount of data out there. A lot of it goes into our Care Close to Home monthly reports, which then go to the commissioning board, and they hold us to account for our performance against some of those measures.
Thanks. I mean, it would just be good if some of these indices of success are in the public domain. I think we'd find it reassuring.
So we're doing some work specifically on that at the moment, and it's not just about putting some of the performance indicators for locality into the public domain. It's actually trying to think about what the system performance indicators need to be, and going into a bit more detail than just the fairly sort of high-level measures, a couple of which I put into the report around delayed transfers of care and A&E 4-hour waits. So partly drawing on the work that the Care Quality Commission is doing because they've already developed a set of a data pack that's got a set of indicators about the system performance. We're doing some work locally across all the organisations that are here to identify what the key performance indicators for the system are, and as soon as we've got that sort of nailed down and got the data flowing into it, that will be going through to the integrated commissioning board and being shared more widely.
Thank you. Right. Can I just double check, first of all, last winter we had closure of the HRI birth unit. Can I just check that your stress testing that you've undertaken ensures that you can keep the birth unit in HRI open over this winter, barring any flu epidemics, I suppose. But can you just confirm that?
I can absolutely confirm that. That's part of our big learning from last year, and we certainly have concertinaed all of our elective activity into the first 9 months, so we've got a very different plan.
Okay, thank you. And can I just remind the services that if you have to temporarily stop a service you need to ensure that scrutiny is notified and the reasons for that, okay? Can we ask as well, I think last winter, when you came in the January, very helpfully provided updates on a regular basis as to where we are. CHFT certainly did that. Mid-Yorkshire were a little quiet on that. But if we could have something, generally maybe the CCG could coordinate or something, to update us on a regular basis as to what the position is through the winter, I think that would be useful. Can I just check as well, Locala said you're not doing flu jabs this year. So can I double check how are primary care administering flu jabs to people who cannot get to surgeries? Can I just double check that, please?
Yeah, the practices will be doing visits. The practice nurses will go out to the housebound and to the care home patients, and it's part of their plan to do so.
Right, okay. And can we double check as well that you monitor how the promotion of the flu jabs is being done by primary care? Because in a lot of places you have to actually go into the surgery to know that the flu jab's available and that the dates, and then ask for the dates when the particular flu jabs are being given out. And so how are you ensuring that practices are proactive in actually making sure that all their patients who should have that flu jab have received it?
Again, it's part of their planning. They do put things on prescriptions that flu jabs are here now, book your jabs, and posters, that kind of thing, as well as identifying patients as they come through the surgeries. And certainly if they're housebound, they've got a list so they know all the housebounds are and systematically work through that list.
Right then, so I think there's been several things that have been mentioned. So improvements in communication seem to be quite big in this document on the lessons learnt. And I would have thought that that was something that was worked on throughout the year. And it's surprising actually that that is there. I would have thought that you were all working closely anyway. But we've asked as well about integration of the winter plan for Kirklees. So there is a plan for Kirklees. We understand that you've got to do plans on the acute footprints that include Calderdale and Wakefield. But if there is a coordinated winter plan for Kirklees, and certainly that would fit with what the CQC are looking for in the coordination of the health and social care across a particular place. All right. So we'd like to see that, I think. Hospital avoidance, there seems to be a lot of emphasis on what happens when somebody gets into hospital, and I think hospital avoidance, I think we would want more emphasis as well on hospital avoidance. And that's just not on the winter, that's worked throughout the year. Not lose the outcomes for people in all of this. We've mentioned that before. It should be in the forefront, and that a solution is found to how that people's voice can be brought into this. I think we would want to know that you've looked at that. Focus on the practicalities, what happened, what went well and what did not. We've asked about that. The dates on when actions will be taken. I think we'd like to understand that your action plan is being actioned in a timely manner. And also, it's a concern that people are receiving different services across Kirklees. There's slight variations in service, and it should be best practice across Kirklees. Have I missed anything out that anybody would want to bring up? I think there was also about the mental health representative, there being more than one mental health representative, and I think we'd want to see that. And there seemed to be emphasis as well on problems in social care, and I think it's the hospitals sometimes fall back on when we can't discharge because of social care, and social care saying, well, we're okay. I think that communication and better understanding of everybody's capacity would help in that, so there wasn't this tension during the winter period. Okay. Anything else? I got everything? No. All right then. Thank you very much on that item, and we will move to the ambulatory emergency care item. So those that are here for that item, if you want to move to the front, please. Right, okay then. So item 5, ambulatory emergency care at Dewsbury Hospital. This was a component of the reconfiguration, meeting the challenge that ambulatory care would be put into Dewsbury Hospital. The report says that you wish to have ambulatory care closed over the winter period. If we've read that correctly. It has been closed, I understand, since August anyway. Your report says that it was closed from 25th of December to the 5th of March as well. So looking at that this year, it's probably only been open about 3 months. I would remind Mid Yorkshire that you did notify us in August of the problems you were having from the summer period, but you didn't notify us in 2017 or in January even that you had closed it, and you need to notify us of any service that is temporarily closed and the reason for that closure. Okay, that is a requirement that is set down. So do you want to introduce this item, say anything on this item? We've plenty of questions, as you no doubt appreciate. And also, can we have the CCG's perspective on this? Okay. All right.
Okay. Yeah, so Trudy, I'm the Chief Operating Officer. We've relocated the services of ambulatory care for the patients of Kirklees to the Pinderfield site. So we continue to provide the ambulatory care service. It's just not currently in Dewsbury Hospital. And that is due, as you've just stated, to workforce issues. We are heavily dependent on a locum workforce, so 50% of the consultants that we employ within ambulatory care who are acute physicians are locums. That means that they are not bound by the same employment terms and conditions with annual leave. So we would normally, in a workforce, allow so many people to take annual leave at a time, whereas a locum doesn't have to give us that notice. The pressures we've felt, particularly over the Christmas period and the summer period, are associated with when there need to be high periods of annual leave when people choose to take holiday. And it caused us to have a very inconsistent service on the Dewsbury site. So that has contributed to our long-term provision of service, because you can't train advanced nurse practitioners without reliable support and training on site available. So consolidating the service on the Pinderfield sites allows us to do a better training service and allows us to actually increase the hours of opening, because we're providing a more comprehensive service on a single site rather than a less comprehensive service on 2 sites. And in relation to the question you were going to ask me about ambulatory care and the success, that's how we managed to achieve more patients going through ambulatory care last winter, because we were actually able to open for longer on a single site and use alternative workforce to support. So we were able to bring in workforce such as highly trained paramedics to support within the service, which we can't do if we run 2 sites because we haven't got clinical supervision that is able to work on those 2 sites. So that consolidation provided us with better opportunity to offer admission avoidance services. We recognise that the patients of Kirklees deserve exactly the same access to ambulatory care, so we will transport people to the Pinderfield site to make sure they get that. And where we can increase alternative services at Dewsbury, we are doing that. So in terms of our frailty unit, that was originally not part of the acute hospital reconfiguration plan, but we now have a very successful frailty unit. And through October, we're working with local care homes, Locala, and our consultants as a result of these changes to increase activity and have direct admission to frailty for older people to prevent them having to go to A&E. We've also launched improved surgical pathways on the Dewsbury site to mean that patients don't have to transfer down to Dewsbury because that workforce is down to Pinderfield, sorry, because the workforce is available. But this acute physician workforce is a real problem for us as it is nationally.
So I don't know whether people are aware, but the discussions we now have come together in the Joint Acute Working Group, which brings together North Kirklees, Wakefield CCG and the Mid Yorkshire Hospital Trust, where the outputs of the acute hospital reconfiguration are discussed and any future planning around review of pathways, where there are system pressures in relation to, say, ophthalmology, which has been one of the key areas at the moment, and ambulatory emergency care are discussed. So we ensure that the whole process is followed. So an impact assessment has already been undertaken around the ambulatory emergency care proposed closure at the moment, and that's been supported by the Joint Acute Working Group. That will then have to come back into both CCGs because that is not a decision-making group currently. It is a recommendation group, so there will be further discussions within the CCGs about this proposal. There is also a joint board-to-board from North Kirklees CCG governing body with Wakefield governing body in November, where they'll be looking at the outputs of the acute hospital reconfiguration report that's been undertaken and then plan for any future next steps and further discussions with the Trust. So that's the proposal that we will be considering. It will come back in January where a further impact assessment will be carried out. But the view of the I can speak for North Kirklees CCG, actually patient safety and the quality of care that patients receive is paramount in all this. And while if we were in an ideal world and staffing was there, it would still be absolutely open on the Dewsbury Hospital site. The staffing is not there. And so, as I say, in the interest of patient safety and the quality of delivery of service and also the increased access hours, we will probably support the closure, but I can't say that definitively because it will have to go through our governance process. We'll also take into account the impact it will have on the wider system, because obviously if more patients are then at Pinderfield, that potentially has an impact on social care colleagues, on the Carla, about any further follow-ups, and while they hope they can potentially be undertaken at Dewsbury, if they do have to go back to Pinderfields or there's some longer-term inputs from the wider system, we'll have to consider that. And with other partners, because voluntary sector also supports some of these individuals. And also, obviously, the CCG will refer to the national guidance around any service changes. So we have very clear national guidance around service changes, whether it's substantial, whether it's a closure, decommissioning, recommissioning. So we also will be considering that document when that is discussed within the CCGs. And that, again, will be a conversation with the Trust at the Joint Acute Working Group.
Can we just clarify, please, how long a period of time this ambulatory care is envisaged to be closed for safety reasons because of the lack of staff? Because you say you have fully functional AMP team by 2021. So can you clarify, please, how long this service will not be operating in Dewsbury, please?
I can't give an immediate date because we continue to try and recruit. So if we recruit staff, we'll be able to re-provide the service on the Dewsbury site. So we are continue to be out to advert for both acute physicians and advanced nurse practitioners. So we will reopen the provision as recruitment allows. If we are unable to recruit, our A&P workforce training programme it's a 3-year programme. So we have a number of staged people. They're not all 3 years out. Some people are at 1 year, some people are at 2 years, some people are nearer. So as our workforce becomes more robust, we will reopen the service as soon as reasonably possible.
Now, do you want to come in with a question? Because you first this time.
Well, I was just interested in the as I say, the report that said that ambulatory services went well. Is that because you had a lot more transport, or how did it work? That a facility that you thought you needed, you found you didn't need in order for the service to work well?
The facility at Pinderfields ran extended hours last winter, and that worked well because patients with ambulatory care conditions are predominantly lower risk patients, so they aren't patients that are very, very complex. If ambulatory care is not available, however, there is a risk that those patients are then admitted into the bed base, and quite often the hours of attendance, our peak hours of attendance as per every other hospital in the country, is sort of from 2 o'clock in the afternoon onwards through to about 10 o'clock. So consolidating the service on a single site allowed us to keep ambulatory care open for a much longer period overnight, which meant we didn't have to admit people who didn't need to be admitted. We wouldn't have been able to do that if we'd run it on 2 sites, because we'd have had a less workforce, even less than we had, so we consolidated it. So that's how we managed to make it work better.
Thanks. A couple of questions. First of all, the paragraph that deals with the advanced nurse practitioners. Is this a kind of alternative strategy that once you've got your AMP service fully up and running, which might be by 2021, that the service, the ambulatory service at Dewsbury would be provided solely by advanced nurse practitioners, or would you have a mix of AMPs and consultant staff? That's the first question.
Yeah, we've moved to have a mix. Advanced nurse practitioners are independent practitioners, particularly when they're able to prescribe, but they work to certain key conditions, so they'll work to prescribed pathways, whereas our acute physician workforce prefer to work beyond the boundaries of specific pathways. So they will visit our A&E department and find patients who aren't on a specific pathway, such as someone with a DVT. They will be able to provide support for patients with slightly more complex needs. So a mixed service is certainly our preferred option. But while we move to an A&P service, we can then at least provide the basic package of, I think clinically there are 25 defined ambulatory care pathways, but I genuinely couldn't name them all for you right here, right now. But those A&Ps will be able to work to those with clinical supervision. But our aim would be a blended approach.
So just to clarify, if you're not able to recruit consultants by 2021, would you run the ambulatory service at Dewsbury solely with AMPs?
Trained AMPs, yeah, trained AMPs could run the service on prescribed pathways with clinical supervision on an outreach basis from the Pinderfield site, yes. Yeah, and there are obviously other consultants at Dewsbury, such as the A&E consultants, but clearly we don't rely on our A&E consultants to provide a longer term service because they're so busy at our front door, but they are there for advice and guidance should they be needed, as well as our surgeons and geriatricians that are on the Dewsbury site.
Thank you. Second question is, there's a reference to if an ambulatory patient arrives at Dewsbury and they couldn't be seen there would then be hospital transport to take them to Pinderfields on a timely basis. So first of all, there's the capacity. So is there a risk that a patient might arrive at Dewsbury and then it would be a number of hours perhaps before they were transferred to Pinderfield if there was high demand for transport? And the second element of the question is, how do they get back? How do they get home?
Okay, so that very much depends on the patient's need. Some patients prefer to make their own way. If they're very unwell, they probably will not fulfil the ambulatory criteria anyway, so we'll be transferring them normally through hospital transport. We do have capacity concerns with hospital transport, so part of our winter plan is an additional investment in transport, so we have purchased more capacity from Yaz to support this year, and if clinically suitable, we can provide taxis for the patient to transport down to the Pinderfield site if that's appropriate. But it very much depends on the needs of the individual and what transport they require.
So would the return journey ideally be from Pinderfields to the patient's home, or would they be taken back to Dewsbury to then get home under their own steam?
No, they're home. They're home, yeah. Yeah, we take them home.
I just wonder, please, how you train your AMPs, because they seem pretty critical as well to getting this resurrected. Do they do a recognised university course? Or
Yes, they do. They do a recognised university course and on-the-job training with clinical supervision. So they come out with a qualification, and there are various modules within the AMP training which can top up the qualifications. So advanced prescribing is a module within that. We have ANPs across our hospital, but quite often they become very specialised within the areas. So we have surgical ANPs who have specialist knowledge and have done surgical modules. We have orthopaedic ANPs. We have ANPs who work in A&E. And where possible, we try and make sure that our ANPs are skilled in multiple areas, but there are specialist modules that you undertake.
Yeah, so in the academic programme they do an advanced diagnostic skills programme and
yes, they do.
prescribing training.
Yeah, they do.
And get up to speed clinically.
Yes,
on
they
their
do.
days in the hospital.
Yeah,
and is that accredited by NMC?
It is, yeah. They remain registered nurses, so professionally reporting to our Director of Nurses, although they work alongside our consultant workforce, because quite often they might replace a junior doctor if we've got a vacancy on the junior doctor rota, but they do maintain a registered nurse, the advanced nurse practitioners. There are others, urgent care practitioners, who don't need to be nurses. So they can come from other backgrounds, such as physiotherapy or paramedics. So there are a variety of training programmes depending on what your baseline is, but our advanced nurse practitioners remain on the NMC training programme. Yeah.
How much work has gone into actually getting the community to know that these services are not available from Dewsbury anymore, and then they need to go? You know, rather than obviously having them to go to Dewsbury and find out that they're not going to have that service, how much of that information has already been provided or is being provided to them?
So this isn't a walk-in service, so patients don't just walk into ambulatory care anyway. It's a GP referred service, and there is already a single central number which we run for ambulatory care. So GPs don't have to change their referring behaviour at all. They still ring one number, and we will then organise what happens for patients after that. If a patient self-presents in A&E, they don't generally think, I'm going to go to ambulatory care. They go to A&E, and we will organise their onward care from there. So although the transport to Pinderfields is an inconvenience, which I recognise and I apologise for, we shouldn't have any negative impact on the decision-making of either patients or GPs, because we'll take that responsibility as Mid Yorkshire.
Thank you for that. Just another question in terms of the transport. How is that transport? Is that normal ambulances, private ambulances, or other private methods?
If it's a taxi, then it's a taxi that is commissioned by ourselves. If it is an ambulance, there's PTS, which is part of our ongoing contract with Yorkshire Ambulance Service to increase capacity last winter and the increased capacity this winter. They are working across the West Yorkshire system. There was concern last year from Yorkshire Ambulance that hospitals were procuring bits of service from private providers independently, which prevented them from coordinating a response. So this winter, none of the acute trusts are doing that. We're all working through Yorkshire Ambulance so that they maintain central contract. So any increased capacity that we'll need will be through Yorkshire Ambulance, so it's coordinated, and then we're not in a bidding war or any competition for anybody.
Is there any risk that if you're not able to recruit consultants and the AMP service is not fully operational until 2021, that the unit will stay closed until 2021?
There is that risk, yes. Our actions, therefore, would be the actions that we're already taking to provide alternative optimal services at Dewsbury. So the direct access to frailty, more patients being able to avoid coming down to the Pinderfield site where possible for surgical flows, and clinic capacity, increasing clinic capacity at Dewsbury, so for hot clinics. So hot clinics are a facility that will offer, so when the GP rings the number for ambulatory care, we can offer a hot clinic, which is a booked clinic. Now, it's not necessarily with an acute physician, because if we had an acute physician, we'd be running ambulatory care. But it might be with a geriatrician or a respiratory physician or a surgeon or whoever, whatever services are available at Dewsbury. And we're increasing those at the minute.
Do you anticipate any staff retention problems of AMPs who are in post if the service is not being provided in Dewsbury and they're redeployed temporarily to other services?
No, we don't. We can redeploy those AMPs into our A&E service if they wanted to, but our numbers are so low in terms of fully trained AMPs at the moment that actually one of the drivers for making sure we ran a co-located service is to give them a better training experience so that we can retain them, because otherwise we will lose them to other hospitals.
Okay. Can we just clarify, your frailty wards have not been put in because of the issues with ambulatory care. They were put in because it couldn't be achieved on the reconfiguration. The demand is such that the reduction couldn't be achieved, and therefore you needed the frailty beds to help with the demand. And the demand in North Kirklees is rising rather than going down.
You're absolutely correct. The frailty units were put in as a demand response. What we're able to do, clearly our acute physicians have a budget, so if we can't employ acute physicians, we do still have their budget. We've been able to recruit more geriatricians to enhance the service on a locum basis to support direct access for elderly people and enhance the frailty service at Dewsbury. We're trying to use our budget, which is clearly a massive responsibility on behalf of the taxpayers, to give the best service that we can with that budget. And the frailty population is one that we really need to focus on. And you would have seen in our winter plan that actually that's the biggest learning out of last year, that our frailty services need to be significantly enhanced to either avoid admission where possible, get specialist input for frailty patients where possible, or help support an early discharge where possible. So we're using our budget as wisely as we can for that group of patients.
Okay, and your clinics that you mentioned, in the reconfiguration it was said that more outpatients appointments would be available at the Dewsbury site, so people were not having to go to Pinderfields or Pontefract as much, and they've been able to have their outpatients appointment more locally. We're not seeing at all that has to any great extent happened, and therefore I'm wondering, your hot clinics, if somebody needs a hot clinic, are they being directed to the nearest hot clinic, or are they being directed to the next appointment hot clinic? And I appreciate that sometimes they're going to need the next appointment by the very nature of it, but it is people travelling distance to Pinderfields rather than having those outpatient facilities available at Dewsbury.
Yeah, I fully appreciate the question, and I understand, and the tension between now and near can be very, very difficult. We do need to do much more on our hotline, which is the GP number, to make sure that the clinical needs of the patient takes priority. At the moment, that line is answered by admin staff who then go to clinical teams for support. So, and then there's a determination of, actually, I need to see you today and the next appointment is here, or it can wait until tomorrow and the next appointment is nearer. We are hoping that if we put some clinical support in that room, which links to our community services more effectively, we might be able to ensure that the patient gets the most timely and nearest appointment, which is much better integrated rather than come to any hospital site if necessary. I'm hoping that work will really come to fruition over this winter, and I'm more than happy to come back and feedback on those pathways.
Yes, a question for the CCG really. If there's no ambulatory service up until 2021, so there wouldn't be any kind of full A&E service available in Dewsbury, and if HRI A&E is downgraded, I appreciate that's an if, that would mean there wasn't a full A&E service anywhere within Kirklees. I just wonder what the CCG's view would be of that situation.
Obviously, that would be a consideration that both CCGs in Kirklees would need to discuss, and the implications of that. I think from a North Kirklees perspective, Dewsbury A&E is still a 24/7 consultant-led A&E. There is the consideration that the public say it has been downgraded, but when we agreed the AHR changes, acute hospital conversion, it was to still have a 24/7 A&E consultant-led.
Yeah, but can we just be clear? Blue light ambulances are not going into Dewsbury, which is what a lot of people believe is a fully functioning acute A&E service, okay, which they're going into Pinderfields. When you say 24/7 consultant-led, does that necessarily mean there is a consultant there 24/7, or there is a consultant available to people 24/7? There's a difference, and we need to be clear on what the difference is.
We don't have 24-hour consultant presence in any of our A&E services, Pinderfields, Dewsbury, or in our urgent treatment centre at Pontefract. We have consultant-led services until consultant on site until 10 o'clock at night, unless there is a clinical requirement for them to stay, and then registrars overnight both at Dewsbury and Pinderfields. So we don't have a consultant 24/7 on either site.
And the consultant is on call out and has to be within 30 minutes of the...
Yeah, they are on call and they return to site. Dewsbury continues to run a very busy resus. Lots of patients at Dewsbury walk in quite unwell because it's very conveniently located for the public, and we have absolutely no plans to change that whatsoever. That service needs to be maintained, and our consultants will come in, whether it's to the Pinderfields or the Dewsbury site, out of hours, dependent on patients' need, but we do have consultant presence in both accident emergencies until 10 o'clock at night.
You just need to be clear on what you're meaning by consultant-led. Okay, all right. Are there any more questions on this area? The ambulance capacity, you've said that, but ambulance capacity had to be put in, extra ambulance capacity had to be put in for the reconfiguration as it was. So that means extra ambulance capacity for this as well, if needed, although you're using the patient transport rather than the emergency ambulances where appropriate, yes?
Yeah, so additional transport was put in as part of AHR. But last winter we put additional transport on top of that to meet winter pressures, and we're planning on repeating this year. The volume of patients, although isn't large, obviously any impact on our ambulance services is key, so we'll continue to use alternatives where it's clinically suitable.
Right. So I think we need to understand what the impact on the ambulance service actually is, because obviously they're already doing emergency ambulances already going to further to Pinderfields or to other A&Es if they have to go to the nearest one from North Kirklees. And let's be clear, if they have to go to the nearest one because of the pathway, Pinderfields is not always the nearest one from parts of North Kirklees. Leeds and Bradford are nearer. And if it is a particular pathway, then they would go to Leeds in any case, yes? But I think we need to understand about the capacity issues on the ambulance patient transport we also need to understand about the workforce, because I know there's a piece of work in West Yorkshire about workforce, and you're saying you're relying on locums, but is there any sharing of workforce across West Yorkshire where services are struggling because of locum provision, that they can share staff more easily? Is there any of that work happening?
Yes, there is. We are part of the West Yorkshire Acute Hospitals Trust, WIAT, and where we can provide mutual aid, we will do that. So an example is in dermatology services, where Mid-Yorkshire do have a fairly robust dermatology service, and that's not necessarily available across the rest of WIAT. So we're now working together to look at, in fact I'm meeting with Coldstone Huddersfield this next week around providing outreach clinics where our consultants will go into Coldstone Huddersfield. With acute physicians, the issue is the national shortage rather than it just being about Mid-Yorkshire.
I was thinking more of your nurse practitioners as well. You know, if there were already some trained nurse practitioners from other trusts that could be brought in, have you looked at that at all?
I haven't looked at it specifically with regard to this area because I know from our Chief Operating Officer networks that ANPs in this area are scarce, and every hospital is running training programmes. However, there are particular pathways where we are working. So we're working with South Yorkshire, particularly Barnsley, as they change their stroke services to bring stroke specialist nurses over to Mid-Yorkshire hospitals, which cover the full patch. So we are considering that, but this area I can do more work to check on that.
Okay. Right, the CCG is looking at this in January, you said. So are you looking at the impact assessment? Are you looking at the capacity, the ambulance, the workforce, and whether the service will be closed till 2021?
Yes, as part of the report back to the Joint Acute Working Group, we can ensure that all those areas are covered and reported on, but there will be an integrated impact assessment carried out as part of the process.
Right, I think Scrutiny would need to understand that as quickly as possible. As I said, this service has probably only been open for 3 months this year, and therefore it is very concerning that a key part of the reconfiguration is not operating as was said it would. And I think we would need to take a view. I understand that the NHS has procedures as to whether a change is significant, but Scrutiny also does. Yeah, and I think we would need to look at all the detail in order for us to decide whether it does constitute a significant change or not. And I think we would want to do that as soon as we can, as soon as that detail is available, because at the moment it is very concerning that people are having to go to Pinderfields, and Pinderfields has already got a lot of pressures on it, and that the best outcomes for people in North Kirklees need to be at the forefront of everything. Okay, we appreciate you've had to close it for safety reasons. We would not want patients to be unsafe in any way, but any change that is a longer term change, then we need to take a view as to whether that's significant. All right? Okay. Thank you very much. Thank you. Right then, we move. Work programme is as per the papers. The 6th of November meeting will be the mental health themed meeting. So we expect suicide prevention and an update on mental health services to come at the November meeting. And the Kirklees Safeguarding Adults Board annual report will hopefully be ready for then as well. All right. Does anybody have anything that they wish to raise in regards to the work programme?
Perhaps something that you might want to bring in. Down syndromes, I've had an increase in the way, because of the cuts that are happening, because of the changes that are happening, there seems to be a definite decline in wheelchair services and everything else kind of all joins in, but see if we can bring that in specifically.
Have a look at that, certainly. All right. Okay.
Next time, we had a very helpful lady from Kirklees. Sorry, we had a very helpful lady from the council last time who talked in particular about the M62.
Yeah.
And it might be useful to have an update where they're at with that, because it still seems to be figuring as Yorkshire's beachy head.
We are in discussion at the moment with Mental Health Trust as to what is happening on that. We understand there's some Highways England work that is planned. We are wanting to get more detail on that, but certainly that will be coming as part of that discussion. All right. Okay. Thank you. Yeah.
There was a discussion and a presentation about Scamandon Bridge at the last Kirklees Suicide and Self-Harm Prevention Action Group, and someone from Highways England came along as well. So I think you're right, it would be useful to get an update because there is some work in progress about that. Yeah.
That's what we're currently getting the detail on, and so that Scrutiny can take a view on that work that's happening. Okay. So,
And hopefully they'll have more information about the mocks after they were having it. I think that was definitely...
yeah, the last time they came, they were having trouble doing getting the coroner to agree to the audit that's needed. Yes, we'll ask for an update on that as well.
And just to say that I think it's sort of important really to ensure that Scamandon Bridge doesn't simply relocate. I did mention that at the meeting that I attended as well.
Yeah. Yes, there needs to be, I think there needs to just be more than work on the bridge. Yes. Okay. Thank you very much, everybody. We'll see you next time. Thank you.